Testing, testing, testing. Hi, everyone. Welcome to the prisons abstract session. So we're at time, so we'll go ahead and get started. My name is Matt Akiyama. I'm a clinician and researcher based in New York and one of the vice chairs of INHSU Prisons.
Hi, my name is Yumi Sheehan. I'm a research project manager and PhD candidate at the Kirby Institute in Australia and also an INHSU Prisons Executive Committee member.
So just a bit about INHSU Prisons. We formed in 2019, and we're a special interest group of INHSU as a whole. So we have a prison focus, and we're really happy to be able to present some of the abstracts that are prison focused in this session. We have an annual pre-conference. It was successful this year. We had, I think, around 60 to 70 attendees, and we hope to grow that in the future. So if you're interested, we'll probably have another, we will have another pre-conference session next year. And to plug shamelessly another session we have tomorrow at lunch, there will be another prisons focus session. So I'll hand it over to Yumi for some housekeeping.
So just a reminder that if you're joining us for the conference dinner, it starts at 7 p.m. tonight at Platform on Argyle Street in Glasgow City Centre. Please remember to bring your name badge. This is your ticket if you have purchased one. So without further ado, I will introduce our first speaker. So we have Dr. Kanudeep Kaur. Dr. Kanudeep is a public health professional with over 14 years of experience of working with incarcerated populations and people who inject drugs. Dr. Kaur has a doctorate degree from the University of Delhi in India. Currently, she's working as a project lead for Prisons Hep C intervention in India with FIND, the Global Alliance for Diagnostics. And Dr. Kanudeep will be presenting on a comprehensive HCV service delivery model for achieving microelimination of hepatitis C among the incarcerated population of Haryana and Chandigarh in India. Thank you.
Thank you. Thank you for the nice introduction. A very good afternoon to everyone. And I'll be presenting on comprehensive HCV service delivery model for achieving microelimination of hepatitis C among the incarcerated population of Haryana and Chandigarh, the two states of India. So it is estimated globally that 15.1% of the incarcerated population, they are living with HCV with very limited access to the much needed care. So the state of Haryana, which has a population of 25.4 million, with average of 25,000 prison population at any given point of time, the HCV prevalence is around 8%. And while in Chandigarh, it has a population of 1.9 million and with 1,000 prison population with a prevalence of more than 10%. So, however, a very few prisoners, they are diagnosed and have access to treatment for HCV while they are incarcerated. So to achieve the 2030 global targets for elimination, to achieve the 2030 global targets for elimination for HCV, substantial scale up for access to treatment is needed, particularly among the high-risk groups of prisoners, as well as the people who inject drugs. So we do have test and treat policy in place in India since 2019 and also have a robust national viral hepatitis control program in the country, but still it's mostly catering to the general population and still not available to the prison groups. So the Health Department and Department of Prisons of Haryana, Punjab and Chandigarh, so in partnership with FIND, they embarked on a program to eliminate the Hep C among the prison inmates of these two states. So the objective of the current intervention was to work with the state national viral hepatitis control program to expand the treatment and diagnosis to the prisons and to optimize the service delivery by what lessons we have learned from our implementation of a similar kind of model in Punjab. So let me take you through the HCV care pathway. So all the prisons, they had a functional hospitals and a battery of medical and paramedical staff which are trained by us. So the medical teams, they were trained on the management of hepatitis C, and the RDTs were performed, the rapid diagnostic test, point of care antibodies, they were performed for all the inmates inside the prison as well as at the time of the admission to the prisons. So the inmates with the HCV positive RDT results, they received a reflex blood draw for the HCV RNA testing and the baseline investigation. So we used to collect samples in 2 vials, one for baseline investigations and one for the viral load, and we used to send these to the laboratory impaneled for getting these tests done. So liver staging was determined by using the EPRI and FIB-4 scores, and if the EPRI score is less than 2 and FIB-4 is less than 3.5, the patient is designated as a non-cirrhotic, and the prison medical officer, they could initiate them on treatment right inside the prisons itself. But in case the EPRI score turns out to be more than 2 and FIB-4 score more than 3.5, those patients were termed as cirrhotic, and they were referred to the specialized medical care centers situated in each of these state heads for the further management and specialized care. And after 12 weeks of completion of the treatment therapy, another HCV RNA is performed to assess, to evaluate for SVR12, test of cure. So a total of 15,274 inmates were screened from April 2021 to August 2022. And of them, 4.4% HCV antibody positivity was found, and 97.97% of the samples, the patients, they underwent RNA testing. And of those who had completed the RNA, 76% they were the HCV RNA positive, and of those, 80% could be initiated on treatment. And out of them, 79.9% they could complete the treatment, and 54.9% we can track them for SVR, and SVR achieved rate was 90.3% among them. So talking about the turnaround time, the median days and IQR for the turnaround time for getting the RDT and viral load test was 4 days. With a IQR value of 3 to 7 days, and similarly for the time between the viral load test results and the treatment initiation was 10 days with IQR of 5 to 21 days. Even, I just wanted to mention here that even during the peak COVID times, we tried to continue with the care continuum, and we had several expert sessions and teleconsultations which happened. Even post-COVID, we are trying to continue with all those services. We are using ECHO platform also to make the medical specialist available for the expert consultations online along with the prison medical officers. So to summarize, under the project, we have screened a total of 15,274 prison inmates with 4.4% HCV antibody positivity, and 76% they got confirmed for HCV RNA, and 80% of them could be initiated on treatment, and 79% have successfully completed the treatment, and 90% of them out of those assessed for SVR, they have been cured. So this model of care, now this is fully transitioned to the government partners, and additional efforts they are being made to bring back the people who we have lost to follow up because of their release from the prison. And there has to be a robust system in place for tracking the LTFU from prisons. This is still one of the areas that a lot of work needs to be done. And the experience gained by the prison department through the project builds capacity to expand HCV care to other districts and sub-district correctional facilities in the future. And at the end, I would like to thank and give my gratitude to all the partners for their involvement and unconditional support provided in the project. And special thanks to the project donor, the Gilead Sciences, and INHSU for the great opportunity. Thank you. Thank you so much.
That's great. Thank you, Dr. Kanudeep. While people are thinking of some questions, we do have a few minutes for questions, so please come up to the mics on the side of the room, or I believe you can pop a question in the chat box if you'd like. And I can see somebody has actually already come up for a question, so I might just pass straight over.
Great study and very well conducted. Can you please comment on the SVR rate, because you have 10% not reaching SVR? Is this a compliance issue, what should surprise me inside the prison? Or is this already reinfection? Can you comment on it?
Yeah, so thank It's a mix of two. So there could be some reinfections. We are trying to reach out to them to understand why there is a gap of 10%. Because what we could feel is this could be because of reinfection, and there is some compliance issue as well. But these both factors, as you pointed out, are the major reasons behind that gap of 10%.
And a compliance issue inside a
Inside-
closed prison?
Yeah,
How-
absolutely. I totally agree with you. It's a closed setting, but still you cannot force people to eat the
Okay.
medications. You can still, convince them, try to you can counsel them, but you cannot force them.
Thank you.
Thank you.
I have a question, if that's all right, Dr. Kennedy.
sure.
So really great presentation. Thank you for sharing that with us. I noticed that there were 465 that were found to be positive and 374 who started on treatment. So what do you think, or are there any strategies that could further enhance treatment uptake and kind of, I guess, improve or reduce the drop-off between those who are positive and actually initiating treatment?
So, because there is some time lapse between the two once you get the results, and then you have to initiate them on the treatment. So in between there are, you cannot control the release from the prison. So many people, they get released from the prison during that time, and we are not able to tap them in. So we are just working to shorten the TAT for people who have been diagnosed and to be initiated on treatment. So we're just trying to reduce that TAT. So working towards that.
Yeah, that's great. And is there any, plan for point-of-care testing to be introduced in India at all?
Point of care testing antibody or RNA?
So the RNA, so something like the Gene Expert.
Okay, so we have, we have been successful in making the prisons as designated treatment centers, but not as designated as like point of care machines setups there, because it's like a huge setup that you need. Like you need to have dedicated people who will be responsible for taking care of. But we had a tie-up with the lab to get the point of care RNA testing done. So their turnaround time was almost like 3 days. The lag was basically at the prison level.
Yeah, that's great. Thank you. Are there any other questions?
Not the mic, but similar sort of drop-off in the same way around treating treatment and follow-up for a test for cure. There's quite a high drop-off there. We see that in our own prisons as well here in Scotland, and when I work with them in Dundee, it's quite a big issue. So I wonder if you have any sort of advice or suggestions or learnings around trying to close that gap as well?
Yeah, so
Just to summarize for those in the back, Chris's question is fall off between end of treatment and SVR and ways to improve that.
yeah, so I totally agree with you. I mean, we are also struggling to fill up this gap because 56% only we could track back for SVRs, and where is the rest of the population? And I would like to mention here that in, I think not Indian prisons only, but globally, there are a lot of under trials than the convicts. So under trials, they keep on, it's a fluid population. They keep on going out of the prison. So many of them, they are lost to, we cannot track them back for SVR just because of this reason. And another reason, and another thing I want to point out here is, we try to collect their contact details so that we can follow them up once they are released from the prison. But it was observed that only 20% of the contact details which we got from the prison department, they turned out to be the correct ones. So it was very difficult to bring them back. We tried a lot, but still, there is no proper system in place. Still we are, practicing hit and trial on with this particular aspect. Thank you.
Great. Thank you so much, Dr. Kennedy.
So next we have Ms. Nicola Royal. Nicola is a regional BBV delivery nurse manager. She's registered as a nurse for 25 years, working in diverse settings, including emergency centers and prison estates. Nicola has a special interest in bloodborne viruses and substance misuse services. Take it away.
Hi, thank you for the introductions and inviting me today. Obviously, my name is Nicola Royal, the Regional BBV Delivery Nurse Manager for PPG. So I'm just trying to work this out. Why is, sorry. I have, sorry. There we go. So I just want to acknowledge everybody involved in the project, all the people that we've listed, and also most importantly the clients from the prisons that were involved in the testing. Not doing right well with this, am I? I'm right clicking. So those are disclosures of interest. So how did we come about the project that we've started? So the National Health Service decided to try and eliminate hepatitis C by 2025. This follows on from the World Health Organization plans of 2030. We are working well towards this and we're close to elimination, but obviously COVID did have a huge impact over the past 2 years, so we are just slightly behind. So we have a reported prevalence in the prisons of 6% hepatitis C in male prisons and 12% in our female prisons. And the secure environments were identified as somewhere that we would pick up a high prevalence of hepatitis C. It's much higher than the general population of the public. We have about 90% of hep C cases in the UK, which is towards illicit drug use, and 40% of those people in prison are believed to have committed their crimes or been arrested having used drugs prior to that. So we decided to get the elimination programme underway, part of a collaboration working between Gilead Sciences, Practice Plus Group and the Hepatitis C Trust. This was formed in 2019. Practice Plus Group does have currently around 50 prisons in England, so we do provide quite a lot of the healthcare for the prison service. So Yorkshire is my region, I'm sure you can tell from the accent, and we decided to look at our region, which has a general population of 5.4 million across Yorkshire. And we cover 9 diverse prisons in Yorkshire, which are in south and west, which has a population of 3.7 million. Between our prisons, just to give you an idea, we have 1 Cat A prison, which is a high security male prison, 2 Cat B remands, 3 Cat C training prisons, and we have 1 Cat D, which is a female. We also have 2 female, 1 Cat B, 1 Cat D in Yorkshire. And we have a capacity of around 6,000 prisoners in total. So in May 2019, when we started this project, as you can see from the graph, we were very proudly sat in Yorkshire at 27% tested, which we thought were fantastic, until we actually looked at it, and it's like, that's not very good. But 92% of the residents were being offered on reception. It was just actually getting the guys and ladies. So what did we decide we needed to do? We thought we need to get a plan. So we introduced point of care testing in reception, and we wanted to work towards achieving the microelimination, which at the time sat at 95% of the residents tested within the previous 12 months, and of those RNA positives, over 90% treated or initiated on treatment. But the most important part of this was the robust reception testing that we needed to have for the ongoing testing and treatment when they were arriving at the prison, because once they were in, especially with some of the prisons, it's very difficult to capture them once they've passed the reception. And one of the biggest parts of this was to raise awareness and, most importantly, reduce stigma, because we all know the stigma that's around it, and that's one of the biggest battles that we've had to come across. But we had an amazing group of people, the Hep C peers, that came in and helped. And I do need to just mention Ambrose at this point, who is one of our peers for Yorkshire. He is in the audience. I'm not going to point him out and embarrass him. But this certainly wouldn't be where we are now if it wasn't for him. But we do have the peers in all our regions and all our prisons, and they're just amazing. And one of the biggest things that they do is they do the train staff, they train the prisoners, they train the nurses, the officers, get that harm minimisation talk out there, which is the most important part. And he goes in endlessly, delivering his HAP training and certainly helping me. So how did we sort of monitor everything we were doing? Most important thing is we developed our dashboard, which gave us a benchmark of where we were starting, and we monitored the data. We introduced manual data in all our sites, where each site was held accountable each week. You know, how's your testing going? And the biggest thing we found was communication, which was key. Regular meetings between all of us stakeholders, so the Hep C Trust, the ODNs, the nurses, the liver specialists. We'll all have a meeting initially once a week, just to see where everybody was, what were the problems, how would we overcome these. And it's all about the screenage and linkage to care. And the hospital team's absolutely invaluable. We have some amazing clinical leads, some amazing ODM managers, which have really helped us. And then the community teams, we also link in with community to make sure that this is followed up. So we had a framework. The BBV pathway toolkit was created and implemented. So then we worked towards the micro-elimination, which is that big word that everybody wants to achieve, isn't it? We're micro-eliminated. So we had to optimise reception testing. So we plan as soon as they arrive on site, they are tested in reception. Some sites do this on first reception, others it's done on second reception. We do have some complex prisoners who it's not suitable to test them on day one, so they do get tested within 7 days of arrival. And then we do the high intensity test and treat programs where all the sort of national teams, the Hep C Trust, the ODNs, will all go into a certain prison that we've identified, and we test the entire population of that prison, so we know that status. And through that, it's all about the hits will capture those that, so prior to the reception testing being in place, we've got a lot of men and women who are already in the prison who we've missed, so then the hits will capture those men and women, and then that just ensures that we've got the whole population engaged. And that we also, like our peers, will train at these events, and we'll have prisoners from inside who will come and be peers for us, and that just keeps the engagement going, keeps the communication, and make sure everybody's got that general knowledge. So, the results, which is what everybody wants. You want to have a look at your data and see how you're doing. We went from 27% in Yorkshire, so tested within 7 days, from 27% to 91% in June this year, which I think that's amazing. We did actually at the time have one of our prisons who were very proudly sat at 1% tested. They tested one man and was so proud. And it's like, no, you know, we need to do a little bit better. And I've just done their data this week, and they've had 102 receptions this week and tested 100. So they're doing a bit better than their 1% when they initially started. And the two grey bits in the middle is when obviously COVID restrictions came. The first one we did nationally see a massive dip in reception testing, understandably. But they did manage to pull that back. And then when we had the second lockdown, they maintained their reception testing, which despite everything going on, is really good. So we do have, so the data that you're seeing is combined for 8 of the 9 prisons in Yorkshire, and those 8 prisons have been recognised by NHS England as micro-eliminated. But the ongoing challenge that we have at all sites is to maintain that elimination, and obviously the reception testing now needs to be over 95% every 3 months on average. So that's quite easy at some sites if you get 5, 6 receptions a week. But on your big remands, so for me, Doncaster, Leeds, who are getting 80, 90, 100 receptions a week, to test over 95% of them every week, does prove difficult. But that's the challenge that we've got, to maintain that and to make sure that we keep everybody interested. The only prison in Yorkshire at the moment that we don't have eliminated is Wakefield, which is our Cat A high security, which has its own challenges. We are trying to get it eliminated. So just for an evaluation, obviously micro-elimination of Hep C has been achieved. Some of them have lost the official status. They all have their initial certificates, which they do still proudly display, and they are working towards keeping that up. But the next phase, obviously, we're looking at time from testing to treatment. We do have Cepheid machines in 2 of our prisons, and we're getting one in our 3rd remand, and that's, you know, changed the time from testing to treat dramatically. We have really good linkage in the Doncaster sites with the Doncaster ODNs, who can start treatment. You know, I think the best we've had at the minute is 4 days, which is getting the treatment into the site and getting them started. So it's just about keeping working at it, keep it going, and just make sure everybody's still engaged. So in summary, I think it's all about making sure you've got robust data set, so you've got a comparison from where you started. Joint working and collaboration, I think, is the key word there. Make sure that all stakeholders are constantly involved and, you know, keep everybody up to date. Have your pathways, your HIP programs, good education. As I say, get your peers in, delivering education and harm minimisation. You know, Yorkshire certainly would not be where it is if it wasn't for Ambrose. And just trying to maintain it now. We've got 8 out of 9 eliminated, and they have me constantly pestering them to make sure we maintain that. And that's it. Even though we got off to a dodgy start.
So we've got about 3 minutes for questions. Looks like there's some people coming up on the left.
Hiya. Just a question from your introductory slide, actually. I was really surprised to see the prevalence of HCV in the female prisons being twice that of in the male prisons. Have you got any ideas why that is?
I think some of it's probably down to in Yorkshire, we do have a lot of female sex workers who also have a high drug usage. But that's a really good question, to be fair, and I'll probably go to Andy to get some information off him and come back to you on that one. But I haven't got the answer right now, I'll be honest. But yeah, I will definitely find that for you and come and find you. What's your name, sorry?
I'm Daryl. I'm from Liverpool Drug Interactions. So come to our stand.
Yeah, fab, I'll come and find you at the end.
Thank you.
Thanks so much. Looks like we have another question, or no, letting him back in. I've got a question. Your peer program,
Yes.
can you talk about what it took to get that off the ground? We know there's such an emerging evidence base for peer programs. Were there any barriers to getting that program off the ground? It looks like you guys scaled it up really quickly. Can you talk a bit about that?
So obviously we work with the Hep C Trust really closely. We've got quite a few of them in the audience today. That their sort of side of things was already running when we started the programme, but obviously they were very much part of our partnership. They are one of the biggest partners that we work with. Getting them into the prisons, some of them has proven very difficult because we've got the barriers, because some of them have lived experience. So to try and get them into some of the prisons. But we did slowly chip away at the governors and the prison services to say, look, this is what they can do, this is what they can achieve. And I think the biggest thing is to win over your prison staff and to show them how good this programme is. Get them into one prison, show what they can do at one. 'Cause I know when we managed to get Ambrose into a couple of our prisons and the great work that he did, the others then sort of followed on and said, yeah, actually, well, he can come in now. But the work that they do is just invaluable, and we couldn't do this without them. They do the HAT training, they train the officers for us, they'll train nurses, they'll go in and train peers on site. So we actually have guys and women in the prisons who are peers. So if there's one of the prisoners has got a problem, obviously these guys can't go in every day, but they've got somebody on site every day. So that just proves invaluable for them.
Yeah, thanks so much for the additional info. We have one question. I think that's the last one we can take for this
Actually,
session.
just to answer the question earlier, it's a fairly consistent finding across high-income countries that women in prison have a much higher prevalence of injecting drug use or history of injecting compared to men in prison, and then that obviously flows through to hepatitis C prevalence. And it's, you have to work harder to get to prison if you're a woman, and so they tend to be a much more worse off group than the men who are in prison.
Thanks,
Thank
Sarah.
you.
Yeah, we find the same thing in US context as well. So we'll have to leave it there. Thank you so much. We'll pass it on to the next speaker.
So our next presenter is George Kalamatsis. George is a health policy professional tackling public health issues at national and European level. He is the chair of the Hellenic Liver Patients Association Prometheus, General Secretary of Greek Patients Association, President of Liver Patients International, LPI, President of the Committee Protecting Rights of Recipients of Health Services, the Greek Ministry of Health. Thanks, George.
Hi. Well, thank you very much for being here. My name is George Kalamitsis. I come from Athens, Greece, and I represent today the Hellenic Liver Patient Association Prometheus. A few words for the association is that our mission is, of course, to provide access and healthcare treatment and advocate for liver patients. And we're more dedicated to marginalized populations, like people who inject drugs, Roma population, homeless sex workers, migrants, refugees, and asylum seekers. Our vision is to become the bridge which connects marginalized populations and the healthcare system. And this is extremely important in a country that the inequalities between marginalized population and the general population are extremely intense, especially the ones that have to do with inequalities regarding financial income. The background and needs analysis for this specific presentations today is that in Greece, the people who inject drugs have a significant burden of hepatitis C, extremely big prevalence of approximately 70%. And this population is overrepresented in the prison settings, which means from the 12,000 approximately total populations of prisoners, approximately 3,000 have been convicted with a drug-related crime, which is either possession or trafficking of illicit drugs. That number is, of course, an estimation because there's other drug-related crimes which are not directly related to drug addiction, but are indirectly related, like thieves, robberies, and etc., etc. So we estimate, and this is an estimation because unfortunately we do not have precise data, that approximately 5,000 people from the 12,000 of total populations are in prisons and have to do something with drug abuse. And another important argument, data, is that the fact that there is a 5,000 people turnover every year. So every year we have 5,000 new inmates in and out. Limited or inexistent access to screening and diagnostics is something that exists in the whole prison settings. The fact that there is lack of healthcare professionals, it exists in the health system, but of course it exists also in the prison settings. There is limited access, of course, to registering, of course, very poor delivery medication inside prisons, whatever the disease is, either hepatitis C. Of course, the problem is even bigger in hepatitis B. The situation is, I think, a little bit better when the patient is living with HIV. And limited access to follow-up and SVR. Of course, there's also poor data in this situation. So the specific program objective has to do, it was since 2019, we started as Prometheus to implement this holistic intervention for HIV microeliminations in prison settings. We believed in the beginning that it will be an easy win to achieve a microelimination. It will be the first microelimination in the country. We thought that this will be an easy project because, logically we thought that this is a closed environment, everybody's there, nobody can go away. We're going to go over there, we're going to screen them, and that's going to be fantastic. But unfortunately, the findings and the barriers that we experienced were too big. So the objective of the specific project is to offer necessary screening and diagnostics and map the real-world barriers that exist in the prison system and restore hepatitis C interventions due to COVID, which were, of course, they were impaired, of course, a lot due to the pandemic. The methods that we used in order to implement the specific initiative had to do a lot with cooperation. Prometheus is a relatively small NGO. We needed, of course, in order to operate and be successful in such a big, large-scale public health intervention, to have the cooperation of the Ministry of Justice, the Ministry of Health, directors of the facilities, other NGOs, nurses, the scientific community, like the doctors. Everybody needed to cooperate in such initiative. The first thing that we did, when we pick up a prison, when we choose a prison, is to deliver working packages to every stakeholder. After that, we provide anti-HCV screening to the total population of the prison. Of course, this is not mandatory; it's by choice. Whoever inmate wants to receive these healthcare services, he is more than welcome. Whoever doesn't, it's okay, and we respect human rights. The second thing which is important is that we are mapping for a social security number, and I will open a small parenthesis here in order for you to understand the context. A social security number is mandatory when in Greece in order to have access in healthcare services. And in Greece is a country also that is near the borders of Turkey, and of course we receive a lot of people who are asylum seekers and undocumented migrants. And unfortunately, undocumented migrants are people who do not have a social security number and therefore do not have access to healthcare services currently in the country. The population, of course, the specific target population is represented a lot in the prison settings, so this is something that has been a huge barrier all these years. So we create a list of inmates who have social security number, and therefore we can provide HCV-RNA, and therefore we can provide to them potentially the treatments. After this, we proceed with examination. We send the samples to the nearest hospital, and when the results are there, we have the social workers of Prometheus who are in close cooperation with the physician and receive the specific recipe. Συνταγή. What's the συνταγή? Prescription. Thank you very much for my English. We receive the prescription, and therefore we go to the nearest pharmacy, which is a public pharmacy, and receive the treatments, and then we can go to the clinic, to the prison, and deliver it to the patients. Of course, we have a lot of loss due to follow-up, due to movements to other prisons, or due to releases. It's something that we experience a lot. During the real-world challenges that we had to face and overcome, some of them were never expected, some of them we did expect them, but we had to figure out how to resolve all these problems. The first of all is that the beginning of the project we experienced a lot of reluctant people, inmates, to come and receive the healthcare service, to come and get tested. And we realized that there is a lot of stigma and discrimination behaviors among inmates and among people that work in the prison settings. So we realized that a prison is a society, as we have outside the society, it's the same thing. But the discriminating behaviors can be more ruthless over there. So people that have been found positive with a blood-borne virus, most of the times are kicked out of the room, and they don't sleep in the beds, and they experience severe consequences. And the case can be even worse when we're talking about hepatitis B, co-infection with HIV, etc., etc. So there is also, apart from the inmates, there was a system. The system was also discriminating a lot with the behavior. There was an internal rule that we realized that prohibited people that were found positive for hepatitis B and C to work in the prison. And working in a prison is a benefit because whoever works has a reduction of 50% in his time that he's doing in his time. So people were willing to work, but whoever was found positive with a blood-borne virus, he was rejected from the kitchen and the other facilities, so he could not work. So this was a negative reinforcement in order for people to seek and know their status. And lack of social security number, as I told you before, was also a barrier that we needed to overcome. So the first thing is that we had to increase the participation rate. In the beginning, the participation rate, the people that were coming to get tested were very low. So we figured out that there is a need to provide incentives. So we provided a €5 telephone card incentives for people to come and get tested. So the people, the inmates who were probably sitting in their bed, feeling, a little bit, Who cares about hepatitis C? We don't care. You can sit here, relax a bit, probably get a little bit high. Realize that there is an important incentive, so they come and get the test. But also we used an empathic approach, which I think is extremely important. We use peers, people who had the experience in prison, people who had the experience of previous drug use. This was extremely important because these were the ones who informed the patient that hepatitis C is a curable virus, an easy curable virus, that transmission is not an issue when we are talking about a prison setting. And of course, we advocate. We implemented numerous advocacy initiatives in order to broadcast to the general public what is happening in the closed doors of prisons. So this is a picture of a famous reporter that we managed to bring him in the prison settings, and he was interviewing a mother who is an undocumented migrant, and she could not provide healthcare services to her child. This was a moving experience for everybody, and of course it moved the situations in order for the Ministry of Justice to provide the Social Security number. So before the initiative, because we are finishing this presentation, as you can see, the second column, the participation rate was unfortunately extremely low. If you go to the third and the fourth especially, or the two last, you can see in Larissa there was, in the 700 inmates, only 300 managed to participate before the incentives and the information material. But when we changed our approach, we saw that participation rates were extremely high. Of course, as you can see through this slide, the problem with the social security number exists. It's still there, and people do not have the ability, even if they are founded positive, even if they know their status, we are unable to link them to health care. So during January 2019 and until 2022, it's from 9 prisons. This is not the total project, but it's only data from 9 prisons. We managed to test 2,400 prisoners, which is the 20% of the total population, and the overall participation rate was 63.8. And the use of incentives increased the participation from 52.3, it raised it up to 82.7. So it's, we think it is an intervention that we can claim that it was successful. The anti-HCV prevalence was 16.8, which is relatively big. It's, I think, hepatitis C. No, I think I'm positive about that. Hepatitis C is the most common virus in the prison settings currently right now in Greece. And almost half of the participants had a social security number, which means that almost half of the participants did not have a social security number and do not have access to healthcare services. Despite the barriers to access DAs in Greek prison, the program was successful, is successful because it's currently happening, identifying, and it is successful in identifying a largest number of prison persons eligible for HIV treatment. And of course it is successful because it has identified specific barriers that government, NGO, scientific community needs to overcome. I need to thank, of course, our sponsor, which was Gilead, for the last 3 years. And we are more, I think, we are confident enough to say that it might be continued up as a project funded by the Greek government. Thank you very much.
That's great. Thank you so much for a really interesting presentation. Is there anyone in the audience who would like to ask a question? No? If not, I do have a question for you, George. So you mentioned that you undertook some advocacy initiatives to try and get, I guess, some of the inmates who didn't have social security numbers. So could you tell us a little bit more about what kinds of initiatives you undertook, and were you successful at all in getting people social security numbers who didn't otherwise have any?
Well, it's a continuous initiative. We had the opportunity during these years to seek for a grant approval from a big foundation that exists in Greece in order to implement a specific project that has to do with advocacy in prison settings. So this project was, the objectives of the project, in order to make a long story short, has to do with implementing a questionnaire in prisoners, but also in people that work in prison settings regarding stigma, discrimination, but access to healthcare services also. The findings of these questionnaires were provided to the Ministry of Justice and the Ministry of Health. We had also the reporters that I showed to you over there who were interviewing real patients that exist in the system and had no access, which is you know, very, when we're talking about human rights and access to healthcare service, especially after the COVID pandemic, which everybody understands how important it is to treat everybody and provide vaccines to everybody. Now what we're, you know, it was common sense now to the healthcare professionals and the policy makers over there that they need to draft a new law, a specific new law, in order to provide a social security number which will have a permanent character, which means that it will be provided to every inmate in the time he comes into the prison settings and will be taken away by the time he is released. So I think this will probably be in the law in a couple of months from now. That's actually what they promise, and this is what there is public announcements.
Yeah, that's great. Thank you so much.
Thank you very much.
I think we're at time for this presentation. Thanks, George.
Thank you.
Thanks so much for the great talk. So next, we're pleased to welcome Dr. Lise Lafferty. Lise is a research fellow at UNSW, Sydney, with positions at the Center for Social Research in Health and the Kirby Institute. Her research interests include lived experiences of people living with chronic illnesses with a focus on people in prisons living with HCV and addressing barriers to care. Over to you, Lise.
Thank you. A couple of things to start off with. I wanted to start off by thanking the conference organizers for having me here. This is really exciting. I always love coming to INHSU, especially as a qualitative researcher. I feel like we have good space here and we are widely acknowledged and accepted. So you're going to see quotes in my talk. I also wanted to acknowledge that I live in Australia. I'm from Chicago. I live in Australia. And in Australia, it is customary, it's protocol that when you talk about research that you've done, you acknowledge the traditional lands, the custodians of those lands upon which the research was done. I'm going to cry for some reason. I'm really sorry. And so I find that really important to do, and I think being in the UK and with the passing of the Queen recently, it really brought out a lot of stuff for a lot of people in Australia. So I think it's particularly important to acknowledge that. And this work was done in Victoria. I live in New South Wales, so I'm not familiar with the pronunciation so well, so I do apologise. But I wanted to acknowledge that this work was undertaken on Wurundjeri and Boonwurrung lands, thanks. But the analysis where I live on Bidjigal land, which is of the Eora nations. That's where I live and work, so that's where the analysis was done for this work. I always get teary for some reason, sorry. I see your problems for doing the next thing. Okay, so speaker fees, great. And then just all the acknowledgements. I mean, this work could never be done without the participants, and they, particularly in this study, were incredibly generous with their time. Interviews were quite lengthy, there was a lot of time involved, and they were amazing. Nobody started my clock, so I'm assuming I get extra free time, thank you. So I'm gonna repeat everything that we've just heard. People who inject drugs have higher rates of incarceration than other people. People engaged in socially stigmatized behaviors, such as injecting drug use, are more vulnerable to systemic discrimination, which is a real problem going into prison as well as exiting prison. In Australia, we have really high reincarceration rates, high rates of recidivism. So I've put up here 46% of people are released within 2 years. That 2 years is the general time frame that people use when talking about recidivism. Just for different thinking of numbers, 63,000 people were released from prison up to June 2021 in the 12 months period. So that's a lot of people going back into prison. If you look at Norway, I've read that their reincarceration rates are around 22%, so they have a very different approach than we do. And so there's a lot of systems failures that are happening, as we can all imagine or are aware of, for people as they exit prison, because obviously if we were doing better with those systems failures, we wouldn't have those reincarceration rates. And trust has been considered critical to community reentry support provision, and that's from the UNODC. So this broader project that I'm reporting from, we looked at people, and I'm going to explain this in a bit, and I've looked at my slides and gone, oh, there's a whole bunch of stuff I've left off, so bear with me as I fill in gaps. But the primary aim of this project was a post-release project looking at post-release experiences of people exiting prison with a history of injecting drug use. And we wanted to capture people, sorry for that terrible word, we wanted to talk with people about their experiences with a range of post-release drug use experiences, people who continue to inject post-release, people who used illicit substances but didn't inject, and people who abstained from drug use post-release, as well as different housing trajectories. So people who had stable housing. They'd come out, they'd moved in somewhere and had relatively stayed put, maybe one move, stable but vulnerable housing. So they'd had a couple of moves. You know, they might be staying at their ex-boyfriend's house. You know, that's not a great long-term strategy for housing. And people who are transient homeless. And so when we were doing the analysis and looking at all of this stuff, trust became really important. So this is sort of one of those like secondary analysis where we missed opportunities for follow-up questions because that wasn't what we were thinking about at the start. So we did interviews. I did not. Sophia Schroeder in the back there did qualitative interviews with 48 people based on those different experiences that I just described. So we had this 3x3 and we're trying to map people into these different experiences and broadly capture the diversity of experiences for people post-release, and that's why we've done 48 interviews. I know that sounds like a high number. People who released from prison within the previous 12 months. That post-release period really ranged, though. Some people we captured like 5 days after they left, so that post-release timeline was quite varied. People were participating in the super mix study, so we got really lucky. We got to recruit straight from another study that had a long-standing history. It's a longitudinal cohort study, so they had a long-standing history with people who inject drugs in Victoria. So it was really easy to identify people who matched our criteria. They had a history of injecting drug use and prison term of more than 3 months or more. And that was specified because that's when it all goes to shit, right? If you go into prison and you've got Department of Housing, there's a timeline of how long that can get maintained for you whilst you're incarcerated and may potentially still be available to you upon release. But more than 3 months, services start dropping you. They write you out of the books. You've lost your housing. You've lost your Centrelink payments, which is our social welfare in Australia. So we wanted that disruptive timeline to how do people reestablish, reconnect post-release. And using this guy Hall's dimensions of trust, 5 dimensions of trust, so looking at confidentiality, competence, honesty, fidelity, and global trust. You don't need to memorize these definitions. I've got little bits on each slide for you. But I don't focus on confidentiality because that wasn't really in our data. That didn't specifically focus on trust, funny that. So characteristics of participants. Most of our participants were male. We did really try and get some women at the end there towards that. Most people had injected drugs at least once post-release, despite our efforts to try and find some other people. And there were different experiences of housing in that post-release period. So competence, and this really focused on, so it's the ensuring provision of the best achievable results. And this really came out in people's experiences of that planning to release prison, that continuity of care when you go from prison to community, and how is that happening for you? And so here Anthony explains, leading up to release, the nursing staff, they put you onto a pharmacy in the local area that you're moving to. I mean, this sounds great. You're being set up. It's being considered where you're going. They give you a prescribing doctor. It's all in place for you. It's quite good. That's not everybody's experience. So here Adriana describes, I did ask them for the methadone doctor for it all to be organized. I did sign the release of information. They didn't send it through. And then her experience was that they were passing the buck from one end to the other about who had missed that, who'd fucked up the continuity of care for her to be able to access the OAT on release. In terms of honesty, being truthful and avoiding intentional falsehoods, and this is from the service provider perspective, like that definition is really from the provider perspective, but it was experienced by people. So this person describes her corrections officer is very understanding. So this is in the community. So she's out on some sort of probation, and she says, I'm very honest with her. Whereas officers in the past, she sugarcoated it with them. I'm not using, I'm clean. And that's not been an accurate description of her experiences because, as we learned from Neve yesterday, people are so vulnerable to reincarceration if they disclose honestly what their experiences are. And then we have again from Tanya, this time I've been pretty straight up. They seem to want to help me heaps. Now in the past, I've shot myself in the foot. And so we had this interesting sort of observation of people feeling this onus of responsibility to be honest, but not feeling like they could be honest either. So it was this trust paradox. And then fidelity, so pursuit of the client's best interest, not taking advantage of their vulnerability. And whenever you have these power imbalances, it's generally the client who's the vulnerable person. And so her community corrections officer, she was an absolute bitch. She judged me. And we don't know, so she goes on to describe that her officer thought, you use big quantities of methamphetamine and getting involved with assault, and that was her first assault charge. And we know nothing about that assault charge. We don't know what those circumstances were. So that is quite highly judgmental to have that put on her. She was very hesitant towards me, very rude. So that's clearly someone that she can't be honest with about what her circumstances and what her needs are, because if she opens up at all, then she's going to be reincarcerated. So this person, I think I was going to skip this one, sorry. So this person explains, so if we think about global trust, it's the soul of trust. It's sort of that extra element of trust that it's holistic, right? So it's all of the trust bits rolled into one. And just entering into a service and getting looked at, I can't do it, created a lot of anxiety, depression. You get looked at different once you've been in jail, and so that's systemic discrimination again that's happening. So just to wrap up, there's a whole lot of judgmental service provision that happens for people in the post-release period, and we really need more non-judgmental service provision. And it's complicated because people are often getting access linked up to services post-release by people who are working for the penal system. So it's not transparent. It's not in the person's best interest. That's how the system is currently designed. So it's a failure. We need to recognize that transitional support and continuity of care are critical. I mean, people talked about so many times of being let down in that, just in the 48 hours post-release period, and that led back to different patterns of life that they were hoping and had planned to go back to. And that may or may not have included drug use for them, but it may have meant connecting with people that they hadn't wanted to reconnect with. So people released from prison create that trust paradox is really there for them, where can I disclose, should I not? And just on that, because this was a secondary analysis, we didn't get a chance to really delve deeper into those. What were your past experiences around service engagement? How did trust factor into that? How have you navigated that previously? Because that wasn't what we were thinking about at the time of these interviews. And we need models of reintegration that prioritize rehabilitation rather than those punitive approaches. So, the Norway model's looking a little bit good from where I'm standing. And services providers should foster encouragement and empathy. And I think we need to find better ways for people to navigate those complex dynamics in the post-release period. Thank you.
Thanks, Lise. Are there any questions from the audience? On the left.
Hi, thanks. That was really good. I'm definitely going to steal your definition of trust. That was really useful. My name's Matt Smith. I'm a researcher here in Glasgow. I was just wondering, it seems like really important work. I was wondering what the next stage is, if you're going to kind of use this to advocate for policy change, or what you think might be the impact that you could have.
So this work was led by Carla Triller. That's a great question, and I'm going to use that to promote this. Carla and Sophia, jump in if I've missed something with this. She and Karen Drysdale have been leading these narrated pieces to try and change stigma. So they had, and I am going to blank on names, there was some big shot actor name in Australia that was like the narrator for Underbelly or something. And they got her involved, and they had people with lived experience help write the pieces. So the data informed these pieces that were developed. They're audio pieces, you can go online, you can listen to them, and they talk about it from a person perspective of, this is what I got this is what my life was like when I got out, this is where things went to shit, this is how hard it was. And it's things that are really out of their control. And then they're doing this project around challenging those stigmas, but so it's going out to a whole bunch of general people in society, and they're being asked stigma questions before they watch the narration or listen to the narration. There's a video that goes with it, and then after, and then I think there's follow-up as well, but we've got some stuff coming out soon. Yeah.
Thanks. Any others? Then we can move on. Thanks, Lisa.
Thanks. So we're moving now into our short presentations. First up is Chris Byrne. Chris is a postdoctoral researcher at the University of Dundee. Chris's work aims to simplify and improve access to healthcare, particularly for bloodborne viruses for people who use drugs in other vulnerable groups. Thanks, Chris.
Thank you very much. Thanks for having me. I've got a quick 5 minutes to share some of our experiences implementing point-of-care testing in a prison in Tayside. So I want to say from the get-go, because of the type of evaluation this was an NHS evaluation, not a research study, and the issues with approvals and governance at the intersection of justice system, we weren't able to approach patients or people living in prison to participate in this. So I just want to acknowledge that from the start. It's just from a healthcare provider perspective, if you like. So that's HMP Perth. It's a high-security prison near the city that I live in that serves the region. Has about 650 men, and there's about a 30% remand rate through the prison. It worked. Disclosures. Alrighty, so this project, we have a highly developed nurse-led testing and treatment system in Tayside. In this prison in particular, it's embedded within the health centre. All the testing and prescribing is done by the nurses and my healthcare assistants within that system. So what we did, we're always trying to change things to see what we want to do next or try next and what works and what doesn't. So we had the opportunity to implement a Cepheid gene expert within our health centre there. So we thought, let's see what the practicalities of that are and try and share this with others who might be thinking of doing the same thing. So to understand the barriers and facilitators from the healthcare perspective, I interviewed some health service staff, including commissioners, nurses, clinical leads, stuff like that, and looked at barriers and facilitators and tried to allocate it against an organized framework because I'm not a very systematic thinker, so it's an easy way to share things. And the one we went for was a consolidated framework of implementation research, and it has 5 domains, and it helps you think about the intervention itself, the external things that may affect implementation within an organization, the internal structures and the culture as well, the characteristics of individuals, so what people think and feel about the intervention you're implementing, in this case the gene expert, and the processes around that. So, did 5 interviews, as I said. We've identified 70 barriers and facilitators, and they're allocated here on the right-hand side against those 5 different domains of that framework. In that inner setting, so most of them were identified in that inner setting. Next was characteristics of individuals. Then there was issues around the process, and in that inner setting, it was mostly barriers. I'm just going to click through this and get it all on the screen. It's easier. And moving through sort of right-hand side, the characteristics of individuals had an even split of barriers and facilitators, mostly barriers with the process, even split again on the intervention, and then mostly facilitators there. So just to give you an illustration, because I'm running out of time already, of some of the issues that we faced. Around the intervention itself, sort of lab and clinical staff found it difficult to interpret the viral load output from the gene expert. It's reported in scientific notation. That was kind of an issue. We don't have an electronic link-up for results. It's a paper reporting process for this currently. So getting that down on paper and having the lab kind of interpret that was just a bit of an issue. Because of the speed, I mean, this is why we all like it. That was perceived as a kind of facilitator. Looking at the inner setting, high staff turnover affected training, so we continued having to retrain people, and that was a barrier for us from the health service side, resourcing that. Although, because of the ethos of the team, if you look at it from that perspective, that really places a really high importance on the patient experience and engaging and sort of empathizing. That was viewed as a facilitator for getting people engaged with testing in this way. When we looked at the outer setting, if you like, and external things that can affect implementation, in the laboratory, the lab staff were unable to delegate sort of the electronic reporting of that paper process for reporting results to sort of administrative staff because of professional regulations which prevents them from doing that, which is just like crazy. So that was an issue for them, and that meant people who costed more spent a lot of time doing an administrative process. From the patient perspective, again, this is sort of routed through the nurses. They thought it was preferable for people with obviously difficult venous access. That comes back to lab staff again on it wasn't in their skill set, so they didn't like doing uploading those results. But again, the nurses thought it made their job easier. Going around the process again, clinical staff, that paper process made people quite anxious actually. They felt like the nurses and the healthcare assistants, I mean, they felt it placed a lot of responsibility on them to definitely get that right, instead of having like an automatic process that just links it to the lab like immediately, which is something we really need to do going forward. Although, because we did do that sort of simpler process, the lab staff felt it was easier to integrate. I was going to, again, running out of time, so just stick these up so you can read them at your leisure. But a few of the sort of quotes, again, speaking to that, the notation process, checked it yesterday just to go and see. It was like this. That doesn't mean anything to anybody. The lab phoned me and were like, what is this? The finger stick sampling process, our nurses and healthcare assistants kind of preferred to take conventional bloods if they could and sample out of that, because they thought that sort of mini cuvette was a bit of a biohazard risk, which was interesting. From the patient perspective, again, a small proportion of our patients weren't keen on getting venous bloods because of issues around how they would feel about relapse and things. But a small but meaningful proportion of people were waiting specifically for this device in order to get tested. And again, read through them at your leisure. Sorry I'm over time. You can come and buy me a drink at the dinner later on, and I'll talk the ears off you around all the detail around this. But again, the main point is it's a bit of a mixed bag, and things affect the process that you don't really expect, like external regulations for biomedical scientists and how you integrate that into routine sort of conventional healthcare. So yeah, again, come find me later and I'll stop talking. Thank you for your attention.
Thanks, Chris. I don't think we have any time for questions. We'll move straight on.
But please feel free to buy Chris a drink later. Next is Dr. Guillaume Fontaine. So we're thrilled to welcome him. As an implementation scientist, Dr. Fontaine works across disciplines and settings to understand how best to implement evidence-based interventions and routine practice to solve challenges within the healthcare system. He's currently a CIHR Banting postdoctoral researcher at the Center for Implementation Research in the Ottawa Hospital Research Institute. Take it away.
Thank you for the introduction. So I'm super excited today to be presenting a small portion of a larger multi-level study we're doing in Quebec, Canada, looking at identifying barriers and enablers to opt-out HCV screening in provincial prisons. This is our disclosure of interest statement. So in terms of very brief overview of the background, so HCV screening strategies are very heterogeneous across prisons in the province of Quebec, Canada. So we have a mix of on-demand, risk-based screening, but at the time of the study, no prison implemented opt-out HCV screening, which is considered the gold standard. So we looked at using state-of-the-art implementation science methods to, help bridge a gap, the evidence practice gap that exists vis-a-vis HCV screening in provincial prisons. So the study we conducted aimed to first identify the barriers and enablers that may impact the implementation of opt-out HCV screening from the perspective of correctional stakeholders for this portion of the study, and to also describe the decision-making process regarding HCV screening and care at a broader level in Quebec provincial prisons. So we used the same framework as Chris, so the consolidated framework for implementation research to conduct the study. So we conducted a multi-level theory-informed qualitative study with key correctional stakeholders that were identified a priori at different levels of the correctional system. The interview guide included questions on barriers and enablers from a system, organizational perspective, but also on policy formulation, policy implementation at the prison level, and delivery of healthcare at the prison level. And we used directed content analysis to have our teams. So we conducted interviews with stakeholders in the Ministry of Health and Social Services, Ministry of Public Security, Montreal Regional Public Health Department, but also stakeholders and regional health authorities. And out of the 39 CFER constructs, 23 were found to be relevant to the implementation of opt-out HCV screening in 4 domains. So intervention characteristics, implementation process, the outer setting, but mostly the inner setting. So 10 constructs were identified as enablers, 9 as barriers, and 4 as neutral factors. As I said, most barriers were identified in the inner setting, but in the outer setting, what's really key is the lack of political will to have a uniform screening strategy across provincial prisons in Quebec. There's also the fact that there's limited human, financial, material resources, and a lack of consideration of implementation issues like planning. Regarding the decision-making process, so I don't know if you can see because it's pretty small, but you can look at our paper that has just been published. So the decision-making process was found to be complex, hierarchical, multiple interdependencies complicating policy formulation, but also policy implementation. But it also allowed us, this process to identify the gatekeepers at different levels and to see who we can work with to make change that are, sustainable. So in conclusion, very high-level conclusion. So the implementation of opt-out HCV screening in Quebec will require change in political will, prioritization of people in prison, and STBBI guidelines and policies, a multi-level stakeholder engagement, and also an assessment of the barriers and enablers to linkage to care and treatment uptake. So if you want more information, you can look at our paper that was just published in the IGDP. So thank you.
Thanks so much, Guillaume. So we're just at time. If there are any questions, we could take maybe one quick one. And if not, I think we're going out for a drink with Guillaume and Chris
Sounds
tonight.
good. Okay.
We can move on to our next speaker.
Thanks. So next up is Rachel Bryant. Rachel currently leads the Hepatitis Queensland Probation and Parole Project to make hepatitis C testing and treatment accessible to those who need it most. Rachel has previous experience in the alcohol and other drug harm reduction space, also harm prevention space. She's also worked in women's health, focusing on chronic disease prevention. Thank you so much, Rachel. Oh, Rachel is joining us virtually. Thank you, Rachel.
Thank you. Can you hear me okay?
Yes, we can hear you.
Great, thank you. Thanks for having me. So I'm presenting Hearing the Hard to Reach, and I would like to acknowledge the traditional custodians of the land that we work on here in Queensland, and also acknowledge that Aboriginal and Torres Strait Islander people are disproportionately affected by viral hepatitis and liver disease in Australia. I'd also like to acknowledge the people reporting to community corrections who participated and enabled us to provide them with healthcare. So just a bit of a background, all jurisdictions in Australia have well-established models of care for Hep C in the prison setting, but these are only for people in prison. So once they leave, that sort of continuation of care is lost, and that care coordination, testing and treatment is not as accessible once you're in that sort of community corrections or probation and parole setting. In Australia, the hepatitis C prevalence is sitting at around 22%, which is much higher than the general community, which is around 1% in Australia. So Hepatitis of Queensland established a first of its kind on-site Hep C testing and treatment model of care for people reporting to probation and parole. And it's a one-stop shop with a GP, a nurse with a FibroScan, a phlebotomist. We do reflex testing for Hep C, and we also offer point-of-care testing in a number of the offices. Our community nurse provides continuous post-clinic support, and we've found that to be absolutely crucial for this cohort. They have, a multitude of other demands, and health kind of drops to the bottom. That's just a little diagram of our clinic model. You'll see that if someone's negative, we get back in touch with them, give them a result and a bit of a brief intervention about keeping safe. Between August 2020 and June 2022, we've run 34 clinics, screened 200 people. 46 of those people were Hep C positive, so that's 23% of the people we saw. Of that 46, we've scripted 37. When I did this slide, it'd be more than that now. 7 people have been referred to a specialist. That's usually because of a very high FibroScan score, and 17 have completed treatment when I did this slide. 66% of the people that we saw had a history or are currently injecting drugs, and 98% of the people that tested positive for Hep C reported that they had injected drugs at some time. So we think that on-site clinics at probation and parole are a great link to care for people, particularly for people who have a history of injecting drug use, and that it can contribute to the elimination of Hep C in Australia. It's easily replicated. We're working with other jurisdictions. Here's some words from our clients. My headaches are gone. Life's so much better. This clinic's the best thing. Gosh, thanks. Thank you.
Thanks, Rachel. Great presentation. We do have a little bit of time for any questions. So if anyone from the audience has any questions. No, otherwise I might ask a question, Rachel. It's quite specific, actually. So I know that in Queensland you have your prison transition worker, Dorrit. And so I'm wondering whether, so I know that the community corrections, you've obviously got your specific population, but is there any connections or collaborations with Dorrit to kind of feed all of those people who are just released from prison directly into the community corrections, if they're being released on parole, directly into these services at all?
Well, we're only operational at a handful of locations at the moment. But yeah, certainly Dorrit's, our community nurse knows Dorrit very well, and they work very closely together, and there is a little bit of sharing of intel about what people are up to and so on. Yeah, but everyone is very aware of where we are and what we're doing. So I know Dorrit's aware of us, yes.
That's great. I guess we haven't, is there another question? No? Otherwise, I'll ask another follow-up question, Rachel. How have you found the community corrections officers, so the staff? What kind of acceptability is there of this program in the prison? In community corrections from the staff?
Yeah, I think the key is that it's really great if you can have a champion. So if you've got a champion in there that really gets their head around it, and then that's your in. So you use that in, and then we've developed a really succinct and we think a really powerful training workshop for the case managers. So it's really important that we dispel some of the myths. There's so many myths about Hep C, about treatment and, the stigma and so on. So we'll go in and just normalise the whole procedure. And I think too, because we have a fibrous scan as well, we use that as a little bit of an in. So we'll say, look, just because someone's coming to our clinic, it doesn't mean they've been injecting drugs. We've got a fibrous scan. They might be curious about their liver health. So we just find ways to normalise this and try and dispel any of that stigma. Yeah.
That's great. Thank you so much, Rachel. I believe we are now at time. Thank you so much for joining this session. And just another reminder and shameless plug of our session tomorrow at lunchtime, looking at harm reduction in prisons.
Thanks to all our great speakers. Thank you.
Thank you so much.